This is a lens that dislocated 15 years after surgery. This is a three-piece lens that was placed in the sulcus. Here's a more dilated view, and you can see transillumination defects here. This is maximum dilation because the patient has pseudoexfoliation, which is often the cause of lens dislocations. It's important to have the operative note. You want to know what kind of lens was placed. If it's PMMA, these lenses would have to come out through a large incision through a scleral tunnel because they cannot be cut. If it's acrylic, of course, it can be cut. And of course, there's always a discussion about explanting the existing lens versus using it and repositioning it. There are pros and cons for each approach. It's important to have an in-depth discussion with the patient. Obviously, if the optic or the haptics are damaged or kinked or scratched, you want to explant the lens. But if the IOL is otherwise viable, you can certainly reposition it as well. So take-home point is know the kind of lens that dislocated, what was involved during the surgery, how it's impacting the eye. In this case, there's transillumination defects. And then a decision must be made about repositioning versus explantation and suture fixation or flange fixation. Sometimes you may not know until the time of surgery when you have a better tactile sense, better view of the internal structures of the eye, because in this particular example, the dilation that I'm getting here is quite limited. So I don't know what else is going on. Maybe there's some sombering ring formation. So with iris hooks, I'll be able to get a better view. And so I often will tell the patients that I'll lean towards one approach, but the ultimate plan will be determined intraoperatively. And I always have backup lenses if I want to explant and flange or suture fixate. Hope you found this to be useful.